Good morning. Welcome to another monthly endovascular live case with our team at Mount Sinai Hospital. My name is David Song. Joining us remotely is Dr. Kartik Guja, the Director of Endovascular Services at Mount Sinai South Nassau. And then let's go to our team in the lab with Dr. Krishnan.
Good morning, David. Good morning, Kartik. Thank you so much for both of you for being with us. We've got a very interesting case here to talk about. I think really presenting it for the sort of decision-making that goes into play, not only in terms of whether we should or should not do this, and then beyond that also what are the devices and why we chose the device that we did. So anyway, in the lab today, we've got Dr. Vishal Kapoor, who's our director at Mount Sinai Morningside, and then we also have, and also he's the associate director of our program here. We've got Dr. Michael Sola, one of our three dedicated endovascular fellows, who's with us. And then we've got Rekha, our nurse, as well as Mac, who's our nurse. Rekha and Mac have been with us for all the live cases this year, pretty much. And of course, we've got our tech team with the amazing Damien. Who else is out there with the tech? That's it. Who? Oh, I'm sorry, Jensen. I didn't realize. Yep, Jensen's also out here. So again, we got a great case. And Kartik and David, when you see it, I mean, it's going to be an interesting discussion that we're going to have. So let's go to Michael, who's done a wonderful presentation for us. Oh, excuse me, I forgot to introduce Ray Lascano. My God, how could I forget Ray? Ray, forgive me. So Ray's behind me. That's why I didn't see him, and I didn't realize that. Ray's been with us. Oh my God, for every single live case since the inception. So everybody out there knows Ray.
Doesn't need introduction.
Exactly, doesn't need introduction. Exactly. So go ahead, Michael. Sorry.
So we have an 80-year-old gentleman with multiple comorbidities who presented to our clinic for severe bilateral lifestyle-limiting claudication resistant to medical treatment and exercise therapy. He has quite a few comorbidities: hypertension, hyperlipidemia, coronary disease, heart failure with an EF of 20 to 25%. He has status post-TAVR. He has severe COPD on home oxygen, prior tobacco use of 50 years, renal artery stenting, CKD stage 3B, as well as PAD with prior right and left SFA stenting. He's on great GDMT for his heart failure, as well as Xarelto 2.5 BID for his pre-AD. His arterial duplex ultrasound show elevated velocities of the right common femoral artery, suggestive of greater than 75% stenosis at that lesion. He also has right SFA disease. His left side is also diseased in the left profunda, as well as left SFA stent, which is occluded mid and distally. This was our initial angiogram for our initial access when he first intervened on his left lower extremity. As you see here, there's severe calcific disease on the right common femoral artery, eccentric, nodular, as well as severe disease on the distal common femoral artery encroaching on the SFA ostium. We were able to successfully intervene on his left lower extremity. Now he's returning for a right common femoral artery intervention.
Great. So thanks, Michael. That's a great presentation. And so this is a guy who's got all the comorbidities, Vishal and David and Kartik. And you could see that, he's a very cooperative patient. He's made a lot of changes in his lifestyle and how he's handling himself. And the idea here is that, we talked about this, and let me just go over our angiograms here. Maybe Vishal can go over. Yeah. So if it doesn't matter about the access, can you go to our angiograms here? Yeah. Okay, go ahead, Vishal.
So yeah, as you can see, you can see from the angiographic assessment as well, which are going to show you the picture. So essentially, as and how it was deemed, the iliacs were completely, essentially normal, non-obstructive whatsoever. The whole disease starts pretty much in the infra, at the CFA level and below. So if I'll play it solely on a DSA, you can see significant eccentric calcification involving the right common femoral artery actually extending into the proximal SFA as and how the ultrasound determined. The profunda is robust, big size, but pretty much looks disease-free at this point, supplying his below the knee, below the inguinal ligament flow, and that's the disease they were talking about. Overall, the stent looks patent. There is some progression of disease distally as well, which we can talk about how to manage them later down the lane. But you can see it's stent lined all the way down with flow going essentially to the to his legs. And there's good actually vessel runoff. There's almost like 2.5, 3 vessel runoff right there. You can see the AT is occluded, but the peroneal and the PT are going down with some distal.
No, PT is occluded distally.
Sorry, the PT is occluded distally. The peroneal is the predominant vessel going all the way down, and the AT as well. So here you can see, and it's providing his collaterals to his PT as well as the AT.
Yep.
So that's where all his symptoms, I guess, is coming from all. It's like multi-level disease with a lot of complexity, especially calcification, some ISR, and some de novo and progression of disease in the de novo lesion and infrapopliteal disease as well.
So guys, I mean, he's a claudicant, so he doesn't have rest pain at this stage. So let me just show you the level of calcium just to understand, and then I'm curious on what you guys think. So you can see here just under dry seat. Oops, sorry.
Oh, hold on.
You can see the negative calcium there.
Yeah, go.
So you can see it even on DSA.
Yeah, so you can see here, so the level of calcium all the way down. So he's got quite calcified vessels with some patent stents, but however has some encroachment of his of the stents with some calcified disease. So the idea here is, I guess two reasons. One is endarterectomy versus not. We spoke with Dr. Rao, who's everybody knows he's with us quite a bit, and he agreed that with this patient, probably an endovascular attempt may be reasonable, just because it's focal eccentric calcium. The guy has heart failure. He's even though he's stable right now, we went through it back and forth, and also the patient preference also felt that endovascular first may be reasonable as long as we don't end up stenting it. But we'll talk a little bit about that. So the endovascular was like a group-based discussion that we've decided to go endo. But now the question is, how to treat and what to treat. And Michael's got all the data ready for us. I'm just going to go ahead, and this is how we're going to do it. What I'm going to do is I'm going to do an IVUS while Michael presents the data, and then we'll come back, and then we'll talk a little bit about, based on the data, based on the guidelines. Obviously, here we know there's patient preference, as well as we have a vascular surgery blessing here to go ahead and try an endovascular. We'll talk a little bit about the choice of therapy. So Karthik David, while you guys are there, while we IVUS, I'm gonna have Michael go ahead and present the data. Michael?
We can get our slides back up, please. Thanks. So of course, whenever we're working with the common femoral artery, we have to think endarterectomy versus endovascular approach. And this table summarizes some of the studies since 2016. It's not overall encompassing, but in summary, at 1 year, endarterectomy has great patency rates, greater than 93%. At 5 years, 78 to 90%. And at 7 to 10 years, the patency rates are still fantastic, 78 to 80%. In the endovascular realm, patency rates at 1 year are not as robust, 78 to 88% at 5 years. In some studies, they go down to 60%, but 60 to 79%. It's important to know, though, with these endovascular studies, that many of the comparison trials are looking at a very heterogeneous population, looking at PTA or balloon angioplasty, stenting, different types of stenting, atherectomy with stenting. So it's not one modality of intervention in the endovascular space versus endarterectomy. However, there are some studies that try to do that. One in particular, the TECO trial in 2017, looked at endarterectomy versus stenting. And per their conclusion, at 2 years, there was no significant difference between patency and TLR between stenting and endarterectomy, acknowledging that in that particular study, the endarterectomy patency rates in the 80 to 85 range were lower than historical average, lower than expected. We also have to think about the procedure itself and the procedural risks and complications. With an open endarterectomy, there is a morbidity associated with the procedure. You can have wound infection, lymphatic leak, and fistula, as well as potential need for surgical take-back, as well as revision. In the endovascular space, depending on what the final modality of treatment is, you could have increased bleeding if you're using atherectomy or higher sheath sizes. And in particular, if you're planning on stenting, there could future complications could occur. So when we're thinking about an endovascular approach, if you're thinking about whether or not stenting is necessary, we need to think about the patient in total. Is the patient going to have a future need for femoral access interventions? So they have significant coronary disease or vascular disease? Because we may absolutely remove that access point going forward. As well, is this the only thing that's keeping a patient from being active? Are they planning on being active after their intervention? And there's a theoretical risk of stent fracture if they're continuing to use that, be very mobile after the intervention. As well, importantly, patient lifespan. If a patient is a relatively robust patient and going to be having a significant lifespan, an endarterectomy may be more appropriate given the great patency long term. So currently, the ACC and AHA guideline for claudication of common femoral artery disease is a 2A recommendation for endarterectomy, particularly if it involves a profunda. But if patient has a very high surgical risk, it's recommended for a 2B to consider endovascular approach.
Fantastic, a nice high-level overview. So looking at the data and everything, guys, I mean, now I'm going to show you the IVUS. It's a long IVUS, and I want you guys to look at everything, a lot to discuss.
Can we start with the first run?
So start with the first run of the IVUS, please.
Yeah.
Yep, run one.
Sorry, got it.
Okay. So we're going distal to proximal here. And you're going to see as we start here. So, okay, so you can see that, you know, this is obviously we did not do these stents, but the lack of vessel prep is a clear issue. You can see the patient has had a lot of stents put in, but you can see the vessel has not been fully expanded. And as you know, today, in today's day and age, as we go forward, you know, the vessel prep seems to be the major issue. You can see there's a lot of areas of unexpanded stents, and also some severe areas of compression, which you'll see right there, like right there. You know, where the lumen is really, really, really down. So the idea when you
Second
look at
run, please.
next run, please. When you look at the velocities, you know, on ultrasound that Michael was kind enough to show us, you saw that the real velocity shift was in the common femoral. There was some in the SFA. That may be because of obviously these proximal lesions of reducing the flow down, and these may become accentuated. So, but if you look at this right now, you can see that the especially proximally, there seems to be a lot of SFA disease, and then distally also the expansion of the stent is also a problem. The other thing I think it's important with IVUS, and we haven't gotten to the common femoral, is that I think the concentric nature of this. There, look at that. The concentric lack of concentric nature of this will also influence the choice of the catheter that we use. You know, right now lithotripsy has become the mainstay of treatment of this type of calcium, especially concentric calcium. And you know, I think this type of eccentric calcium lithotripsy does not do as well as other forms of atherectomy may. So I think that's one of the considerations that we need to have when it comes to looking at an IVUS to decide. And you can see the common femoral also, as you saw right there, had very eccentric calcium. There you go again. And then as you come forward, you can see that the common femoral plumps right up and becomes a very large vessel. This is the proximal SFA into the common femoral, and then now you'll see the common femoral becoming again quite large right there. There you go. So I think that the idea here would be is the choice of atherectomy device, whether you guys would use lithotripsy or whether you would go with something else.
PK, a question. The instant looks very weird, right? It doesn't look like it's. I mean, it looks like more calcium protrusion through the stent.
Yeah.
Than just deformation of the stent. The stent itself looks not deformed on at least on the 2D angiography.
I think, yeah, I was going to mention that as well. I mean, the neoatherosclerosis and the fibrotic component is very less. Yeah. It's not like less of an ISR, but like what PK rightly said, it's just so-called an underexpanded stent sections because of probably lack of pressure prep because of the significant degree of calcification. So we don't know the circumstances of why the stent was put in if there was not enough vessel prep or they were thinking of doing it. Again, stent choices are also an important decision maker in cases where calcified one category of stents, like the self-expanding nitinol, the Supera stents are known to work better in these, having more radial strength rather than your regular self-expanding stents. But again, that's one thing to talk about and
yeah, I agree, Karthik.
Well.
I'm just going to go with a regular cine and just show you the regular cine of the stent. You can see that the stent, I mean, it's not badly expanded, you know, but there are clearly areas of severe calcium extrusion into the stent.
Yeah.
You know, and I think I think I'll give you another view here, and I think that's what's important to look at it in two views to see how the stent actually is expanded. The stent looks pretty well expanded, but I think the type of vessel prep that was used might be the reason why this is not looking as good. And you can see here as well, you know, in three different views, the stent looks very well expanded, except see that spot right there?
Right there.
You see that spot right there? Yeah. So there the stent has been prolapsed, and I think that's the spot where you can see how different views show the effect of the calcium on the stent. And you can see here that this is the major issue with this. So I think that, we have to decide, how would you guys approach this? Vishal and I and Michael spoke about it. We kind of have our idea on how we're going to do it. And, in today's day and age, I think knee jerk, everybody's going to go ahead and just do lithotripsy. And I told you why I think lithotripsy may not be the right choice here.
Yeah, lithotripsy, I don't know if lithotripsy will really work here, right? It looks more like it's an intimal protrusion of the calcium. You might have to modify the calcium itself with some kind of a atherectomy device very aggressively, because just lithotripsying, just breaking the calcium might not be enough for the stent expansion.
Okay, yeah. I agree that's with the stent.
I would probably... there are multiple devices, right? I mean, Rotarex is clearly not a device here because it's not approved for calcified lesions. I think we have, the Pathway Medical device,
Jetstream
device, which is actually a good device here, especially, and the filter has to be used clearly.
And then, I agree with you. I just want David to comment on some of the up-and-coming devices, David. I know that you've worked with the Thor study that's in IDE right now, that we're a part of the clinical trial, not quite ready. And, so I agree with Karthik. I think that, and not having a balloon-based device because of the eccentricity of the calcium. But before I get to David, Vishal, are any of the new lithotripsy balloons any different than the shockwave balloon, especially the AVS, which I know you're part of the trial? Would that help in this kind of lesion?
Yeah, so AVS, again, like PK is talking about, this one of the newer technologies that's coming is the AVS balloon, which is a different way. It's again a IVL lithotripsy with the balloon expansion, but using of different technology on it. So there's finishing enrollment, but my personal experience, the response has been there. But most of the lesions, like PK talked about, were more concentric. It's just the study of these devices in the eccentric calcific lesions is where the real world data comes in. But right now we don't have enough data on that part of it. They seem to work well, but again, right now studying this kind of eccentricity, this kind of degree of calcification, it's not there yet. So agreeing with PK, whether we add lithotripsy to this, would it give us any advantage? Or like Karthik said, just do plaque modification by shaving the plaque off by all the devices that are available, trying to get some luminal gain. And if you don't get it, then maybe add lithotripsy to it if need be for your cracking of the calcium intermediate. But I don't know.
Yeah, I think that those are all good points. David, what are your thoughts on the newer devices, especially the Thor device, which is in trials right now?
So one of the exciting things is that, we understand kind of the limitations of shockwave IVLs, that it's more for concentric calcium. So some of these upcoming devices try to aim to also not only treat concentric calcium, but also eccentric calcium. So the Thor device is a laser-based system that has a forward-facing laser atherectomy combined with laser-based lithotripsy. From the cases that we've done so far, it's been very successful. So with these up-and-coming devices, it's just, improvement upon the existing IVL device, but kind of helping us navigate these other obstacles that we've noticed in our clinical practice. So we're very excited, and it's been very promising.
Yeah, I don't think here a traditional lithotripsy device is going to work. I think that, Karthik is absolutely right. You need a rotational device, either a rotablator, which I think the burst size may not be enough, or orbital atherectomy, which burst size is enough, or a Jetstream type device, which is what we've chosen here to go with, and I think that's the reason. So for
Okay, what are your thoughts on laser, like a 2O laser, like a large laser?
2.2?
Yeah, 2.2, like a large size laser, because even with the Jetstream device, I think for the instant you might be able to get through, or the proximal SFA you might be able to get through, but for the CFA, you still might have to use a calcium modifying balloon, like a lithotripsy balloon, because of the size of the common femoral.
No, I think when you go to the IVUS, you saw the IVUS showed how concentric the plaque is, and I think once we modify the plaque, we can probably use a modified, cutting balloon like a Serenator to try to increase the size of the lumen. the CF, and I think that definitely in this area, the Jetstream device, the 2434 is what we've chosen. It will definitely give us a little bit of a bigger lumen. The issue with all these devices, whether it's Jetstream or whether it's CSI, is embolization. I should keep saying CSI orbital is embolization, and and less likely with laser, but embolization could occur with any of these devices. So what we've done is we went ahead and put what is it called? Spider device there, distal. So the spider is distal into the perineal artery, which will hopefully prevent the embolization and capture it. I'm not thinking I'm going to embolize into the profunda because my idea here is not to treat the profunda, but you never know. But we're going to have to be willing to accept that. We could have put the spider in the profunda and then done the profunda first and got distal access and put a balloon occlusion of the popliteal, which we've done in the past. But I think that in this case, I think we'll just make slow, long runs, especially with the perineal being the single vessel runoff. I don't necessarily want to put a 3 French sheath in.
30 minutes.
The other question is whether you guys would go ahead and do the actual SFA as well, or will you just concentrate on the CFA and leave the SFA alone? Okay, ready?
I would definitely do the SFA, right? Along with it, if you already have a device and you have a filter down, you might as well do the SFA
ready?
at the same time because
no, don't drill. It's an automatic click.
CFA.
You have to.
I know, but I would straighten this a little bit.
David, what do you think?
I completely agree with that. It sounds more like inflamed disease causing his severe claudication symptoms.
Yeah.
We have IVUS imaging. We have a syndrome here. Treatment SFA concurrently with the CFA would be my choice treatment plan for here.
Yeah.
So this is blade. This is blades down. This is blades down mode.
The
small pack-in mode
is called like a Jetstream device. So this device is more like any other atherectomy device. It has kind of a blades which are first done wings closed, like you can see. I think Dr. Krishna is going to magnify it. So there are 2 dark dots and there are wings right in between which are lighter or less radio opaque. These wings, first, when you do this device, you have to do this device wings closed. And the second time, when you run this device, you have to run this device wings open, where you get the maximum amount of luminal gain. This is a 2435 device, which is a 2534 device. So when it's wings closed,
press the Rex.
You don't have to do anything.
When it's wings open,
I want to pull it. This one spider is going to move. I'm telling you.
Make it bigger.
and 35.
Make it the biggest size.
Just so that you guys know in the audience.
I didn't hear the hit the beep. Okay, good. Perfect.
Dr. Krishnan, we have a question. In centers where there is no Jetstream available,
blades up.
Question is 2 laser a good device to use to get a luminal gain?
I don't know, Vishal, you want to talk about that?
Yeah, so I mean, again, it depends, right? So on the vessel size, the 2/3 might give you an advantage as well and add on to the ISR component. But in this case, like I said, I mean, the laser is going to blast it out, but I think shaving off that significant eccentric plaque should also, the Jetstream should perform very well in this case. So that's why that's the device of choice. But if you don't have it, yes, laser is definitely a very good option as an alternative as well in case like this.
So save that image, guys.
Yeah.
So the Jetstream device also does thrombectomy at the same time?
Yes,
aspiration. Yeah, so you can see an aspiration line right there.
Hold on. So we're just going to do a run, and I think it's very important to check the filter, so the filter doesn't get overwhelmed. I think it's very, very important to keep checking on that filter with these devices. You saw that we ran it twice, and then the length of runs also are a big deal. So if there's see how the flow velocities are, whether you're getting any chunks down. So you can see there's already something in the filter. There's already filter's already full. So you can see that the filter is already getting full, and that's what you'll expect. And the idea here is to really make sure that you don't overwhelm the filter. Now we'll see what we've done to the plaque here. And see, the device really works. Look at that; it's much better.
Wow.
So it's eccentric. It works really, really well. And we're just going to do a couple more runs. Concentrate on the proximal aspect of the plaque here.
We should turn blades up.
Blades up, please.
Yeah, blades up.
Yeah, on. Right over here. Really just allow it to work. And this is where the eccentric nature of the plaque you know, and the device, I don't think shockwave, I mean, is really going to help you here, you know, off. So with that being said, what I'm going to do is I'm going to go down, and I'm going to go ahead and which is the area where there was the lesions?
Oh, yeah, in the mid segment.
Yeah, unfortunately, we didn't save it with the glow tape, so
You can still do a roadmap.
yeah, we can do a roadmap. That's a good idea. Roadmap, please.
Yeah, hold on. Got it.
So you can see that one area right there.
Very nice result in the
Blades down.
What is that?
You have a very nice result in the distal CFA. It's really worked very well.
Yep, I'm just going to walk this down now. Okay, Rex, please. You always Rex it down. Okay.
Blades down.
Yep. Oh, it's a 7 French. Blades down.
Blades down. Ready?
Vishal, any particular reason why you do blades down first and then blades up?
Yeah, so remember the luminal diameter as well. We just want to always start with blades down, get a little bit of more luminal gain, blades up, and then try to be more aggressive with doing blades up. So it's like, you know, slow shaving. Initially shave it, get some more gain, and then go to blades up. You try to avoid doing blades up directly unless it's a bigger luminal vessel.
Rex. And we move it on Rex. It helps it go forward, you know. Okay, blades down.
Blades down.
For this particular device, are there specific times for runs, limitations, any type of specialty like Rotoglide, Viperglide that you need, or
blades up,
or anything like that?
Blades up.
So they do have a timer on the console if they focus on it. We usually try to do our old school, no data, but 30 seconds of run, let it breathe, so-called, let the blood flow go in there, take care of it, and then we start again. So that's the normal protocol we do, like any of the other orbital atherectomy devices as well.
Yeah, I think that, you know, it's all about the embolic risk. So off.
Okay, off.
It's all about embolic risk, and I think that's what we're trying to manage here. You know, I think we're definitely going to embolize quite a bit. Obviously, as I told you, that's why I talked about balloon occluding, and you know, but that was quite a long run. Let's hope that we don't have too much debris down below. As you can see, there's no flow now.
Yeah.
You know, and this is
the filter is just very full.
Yep, and this is what I'm telling you. This is the reason why you have to be ready with these devices. So yeah, we're gonna have to go in with the penumbra now. Yeah, so you know, so
this filter is full. I think once you do penumbra,
you want a 7 bolt or a 6?
around the filter.
I mean, the question is with the penumbra, we don't have the regular old penumbra, right?
No,
we all have the bolt system now.
We have the bolt system now.
Yeah.
Yeah, so here, you know, this is one of the reasons we wanted to demonstrate this with the filter, because this is something that's very common, and this is why, you know, we were even talking about getting pedal access and putting a balloon in the AT to prevent any embolization. Very, very common with the Jetstream device to embolize. It's nothing against this particular device, but it is something that you should be aware of. So at this stage now, we're gonna walk this out under Rex. And then we'll take it from there. Ready, Vishal, without moving the filter?
Yeah, just stay right there.
So what we're going to do is we're going to mag up on the filter, and then we're just going to go under Rex, and Ray's going to fix the sheet, and then Vishal's going to slowly walk this out. So press the Rex button, Michael.
I have to unlock the wire.
Yeah,
press the Rex.
Press Rex.
Yeah, gotcha.
And you know, tension on the filter is fine. You know, just want to go very, very slow. And this is the, you know, listen, when you're modifying plaque, it's got to go somewhere. Unfortunately, it goes distal. And this is the case.
Stop.
Okay. So this is a...
You use a 7.0 spider?
Yes, we use the 7.0 spider. It's got a much larger basket than the Embo Shield, because again, this is sort of where we're predicting our complication. Okay, we know there's going to be embolization. Keep correcting. We know there's going to be embolization, and keep going. That's normal. Keep going. You're fine. Keep coming. Keep correcting. Keep correcting.
That was a great idea to use a 7.0
That was above the sheet.
Yeah.
Should be out now. Out, Ray?
So now one or two things you can do. You can either, you know, we can go with the bolt device, which I think we will. We're out.
Pull back now.
Okay.
Now it should be out.
Okay. You got the bolt device? Give me the bolt device.
So give me a 7.0 bolt.
So we're going to set up the 7.0 bolt. No. 7.0. Yeah, we need a big one. Yeah.
Yeah.
So now the problem is it going to track
Bulky.
Karthik?
Yeah, that was.
Wait, is this the new device with the new soft tip, right? Yeah, this is the one, right?
Yeah. They have this.
So, and it has a dilator?
Oh, like you mean the?
Does it have the dilator? Is this the one with the dilator, guys? Or is that the 6?
This is a 7.
I think the 6 is the one with the dilator.
Okay, that's fine.
Yeah,
we'll go with the 7.
try the 7.
So what we could, yes.
Like you traditionally use a multi-purpose guide with a large multi-purpose guide, 6-inch guide, and you connect it to the penumbra. You're not doing that this time.
You can do it. I mean, the idea here is, will the penumbra go down is the issue, right? With this level of calcium, with all this. So there's a lot of things you can do. So what I tend to do here is put an 035 wire down. So Ray's going to give me a supercore, and I'm going to track the supercore down. And then the supercore is going to allow us to track the penumbra down. And then, we just got to watch the filter carefully. And I'll show you our technique here. So we're just going to go ahead, Karthik, here. And where's my sheath?
Dilator right there.
The sheath is way up. Okay, that's fine.
It's in the external inlet. It's good. It's exactly where it is.
Yep, it's fine. Yeah, that should be okay. So what I'm going to do is I'm just going to go ahead. And this is where anticoagulation is also very important, obviously. So the anticoagulation is important. And so now hopefully this will fly down the way we need it to. And of course it doesn't. So let's see here. I don't want to dissect my common femoral. So let me see if I can torque this somehow.
What are you doing?
So it's not working that way.
Dude.
Okay, so then let me.
Wait.
Almost went. There you go. There you go.
Go. Turn it on.
Let me just lose the loop here. Come on, loop. Lose the loop for me.
Yeah, it's prime.
Yep.
It's prime. All saline all the way.
Nope, not working. All right, let's try it on that.
I have with the dilator right there.
Try it on that, and then if it doesn't go, we'll put it side by side. So let's do this.
Let's do the introducer right there.
For what?
Oh, we can just directly go on it. Yeah.
It's just a demonstration of how complex cases can get just calcium itself, like the bulk.
And then you connect it. I don't want to prime the whole thing.
As Dr. Krishnan demonstrated, you have to be ready with the filter. You have to plan these cases very well to have an idea, right, David?
Take it.
No, I completely agree. That's why it's always good to have alternative access in mind, other plans, other devices on the shelf in terms of bailout for endovascular
I'm just
option.
fixing it.
So it's just, like you said, a good demonstration of how prepared we are and of our experience in dealing with these things.
Okay, so we're in now. So we're gonna go ahead and then watch the filter now. Now you can attack. Yeah. So let me come on this side.
1 second. Ray, fix the filter. I need some slack.
Show me the filter, guys.
1 second.
So again, the whole idea is to prevent the filter from moving, to prevent spillage,
Okay, go. Wait. Let's look where the filter is first. Right there. Okay, good. Let me
mag up on the filter.
Yeah. Got it. Give me. Okay. Hold on. Let me center it for you. Yeah.
Guys, you got to rail me, guys. See the wire? See the wire?
I am. Give me 1 second. I'm just getting the system straight. Give me
part of it is you guys got to understand that it's a combination of, the wire has to be going down. If the wire doesn't go down, then it's not going to work. You know, if the wire is not taut. 1 second.
Yeah.
So when you have resistance, you got to come back up and see where the resistance is. So I'm actually going to start here.
Okay.
I just want to let it run here proximal. So let it, obviously you're not in clot here, right?
Nope. Yeah, no.
So you're not in clot here.
Do you have any torqueability on this device? Like you can.
I am definitely going to torque it, Karthik, but I just wanted to see whether we get anything here. We don't, so we're going to turn it off. So what I'm going to do.
But can you torque the device?
Yeah, we can torque the device. I'm just going to.
Yeah, it's just the stent makes it a little bit more.
And then see if it goes. Nope, it's not. Okay, give me an 035 wire.
Yeah.
So this is when you have to go with an 035 wire side by side.
I think this is a great demonstration of how sometimes
put it through there.
Can be difficult, and then I think Dr. Krishnan is just troubleshooting through all ways of how you can get the device down and save yourself. I think it's a great demonstration. David,
you're right.
The ideas about this thrombectomy device?
Sorry, Dr. Guja, it's a little hard to hear you.
Any other ideas of how to get this thrombectomy device down?
Yeah.
Do you have any other techniques which you
So,
use?
no, I think, obviously I've been taught by, Dr. Krishnan Kapoor and yourself. So for us in this situation, if there's a lot of tortuosity, calcium, instant restenosis, 035 system side by side is the way to go to really give us that support to get the system down.
Yeah, I think you're right.
So-
The stent and the calcium is just deflecting us off the whole thing, and that's why it becomes harder. So see how
Much
what
better.
PK did?
Yep.
Beautiful.
Yep.
Right. That's a beautiful demonstration.
Good.
Okay.
So it's going to
what
take the
Dr.
035
Krishnan
out.
just did is
Yeah.
He took an
closed.
035 wire to get
And to
the
reprime.
support across the calcium.
No, we don't
and
have
just
to.
move the device.
Good.
It's a great demonstration how
It's on.
it's done smoothly and cleanly without moving the filter.
So, this is the problem with the new device. I don't really think it's an aspiration type device. You can see here what's happening. It's really not something what I'm going to do. So I'm going to detach this penumbra and give me a 20 cc syringe, turn it off. So what I'm going to do is I'm going to just attach a syringe proximally and just aspirate physically, because I think that this is the problem here. The problem here with the penumbra is that the old penumbra was a vacuum. It would just suck everything out.
Correct.
The new
Active
penumbra
suction.
here doesn't. So you actually have to actively aspirate this with a syringe, which is what I'm doing here, So I'm getting my 20 cc's here. And then what I'm going to do is I'm going to have Vishal give me a little bit of dye.
Yeah.
And this is where Rekha is already yelling at me to watch the hemoglobin. So, you can actually aspirate quite a bit out. The other technique you can do, guys, is just go ahead and give a little bit of, roadmap here just to see what you're dealing with. I guess that's not contrast, that's saline.
Hold on, let me get you more.
Can I have some contrast,
Yeah.
please?
Again, would
Right.
you go a little bit
That's
lower?
why I took it out.
with
I took it out from there.
with the device before you.
Yeah, I will. I'm just going to inject a little just to see what I have.
It's priming the line too, so that's why.
Just to see.
Take a bigger
And I think this is another good way of seeing what you've got on top. See? So we've cleaned most of it out.
That's very nice.
You see now we've cleaned most of it out. So now we're just going to go in and capture the filter with the penumbra. So now what I'm going to do is attach the penumbra fluid to fluid. Go ahead, press.
Yeah, it's
Right,
primed
fluid.
already.
Primed already?
Yeah.
Okay, hold on.
We just the blood is primed.
So what I'm going to do is I'm just going to come down slowly with the penumbra. Don't
Good.
move,
No.
please.
Perfect. Good. Ready?
No, not ready.
Let me know whenever. One go.
Rail,
I'll give you a
please,
rail.
to me.
Yeah. Rail it is. Rail it is.
Okay,
Hold it
turn
right
it
on
on.
the
Turn
head.
it on now.
Turn it on.
Mm-hmm.
Oh, you can see, and you're right.
That's a beautiful demonstration of how neatly and smoothly you do it without having any issues with it. And it's the filter is completely full.
Okay, now slowly pull this out under active aspiration. Off-road map, guys. So you want to keep it actively
Off-road map,
aspirating and just follow it out. Up top, please.
Mm-hmm.
So one of the things you have to understand is that, unfortunately, unlike the Ember Shield, this, is a
don't need
device.
the wire behind.
You lose the wire here. So hopefully. Oh boy, there's a lot in here. Okay, Vishal's
Okay, I
gonna
got
have to
it.
pull it out there. It's full.
Yeah.
The
You can
filter
hook it
is
back.
massively full.
Oof. Look at this. So let me get a blue towel, right? Here, let me take it out from the basket. But look at this. That is
Tons
real,
of,
some calcium. I mean, it did its job, I guess. Both did their job.
So let's not.
Except for the aspirational part,
Let's
I guess.
take. Yeah, the penumbra. I mean, the new penumbra is great, but I think in these kind of situations, you need an aspirational situation. So mind DSA, so let's see whether we have good flow. I mean, even then, the old penumbra was great because you were able to see everything. The new penumbra, obviously, you're not able to see everything. So, hopefully there's flow here.
probably saline.
No, it's all saline. It's all saline, yeah.
Direct inline flow. Though.
Yeah, it's
so that's a
inline
good
flow.
sign. There it is.
There you go. Okay, good. You got everything.
Nice.
Wow.
Look at
that.
that chunks.
Yeah,
So looking at the
Very
debris,
nice.
is it just more
That was,
calcific
that was
debris
amazing.
from the
Yeah,
actual
it's
nodules?
Why don't you cut it? Put it on a paper, and so we can see it.
Yeah,
right?
that's what I'm trying to do.
Yeah, that's what I would do.
I was taking on a blue towel so you can easily see right here. But
So we'll
sure.
just check our runoff. and then we'll go ahead.
Take this out. All this stuff, chunk.
Now we can still embolize, guys, because it's one of those things. Don't get cocky and think that, I didn't embolize, but anything is possible, So hopefully, God willing, we didn't embolize. It looks pretty good here. It looks like all the way down to the foot, and it's okay. A little bit of movement is okay, and so it's down to the foot, and then you see the foot also fills really, really well here. You can see it filling there. I'm not going to give more down. So I think that, at this stage, it was a good technique and a good prediction of what can happen with these devices. So now the question is, are we going to, let's take a look at that SFA where we did the jet stream, right? Let's take a look at that SFA and then decide.
Jetstream did do its job.
Well, Jetstream definitely did its job.
So if you can focus right here, I'm going to put everything up, but you can see all the calcium. Yeah, right there. If you can see all the right, exactly. So these are all the calcium spicules and the chunk. It came out as a big piece, of course. By taking out, you see the small things. But these are the things. These are the things that actually go down the vessel, like PK talked about. And the problem is, this is not like a clot, which if you give a lot of nitrite, verapamil, or something else, or lysis, it's going to go away. These things are like physical entities of calcium and fibrotic tissue combined. They can actually cause more trouble, and that's where the logic of PK saying, occlude it, put an AT balloon, maybe put an access where you can actually drain it off and try to see if you can get some flow distally, thereby minimalizing your embolization related issues, whatever it might be. So I think that's where the estimation, like PK rightly said, of doing aggressively upfront filter protection is definitely needed in this case. Doesn't matter how careful, how slow, whatever device, aspirational, rotational, works, you always need an extra parachute.
And you can see the proximal nature of the plaque, Karthik, even though we jet streamed. You can see how much plaque there is. It's just a massive, massive plaque. So, the only idea here, sorry, Ray, only idea here is whether we should use a serenator here, because I don't think shockwave is going to make a difference now. So the idea here is, let's take a better picture here. See, in this view, you really can't see. It's posterior plaque, and that's what you saw in the other view. So, here it looks great, but you still have a lot of plaque. So the question is, what do you guys want to do now? What's the largest serenator we have, guys?
So let me ask you this. Before that, we still have some calcium, like you said, some residual calcium. We know we embolize a lot, especially with atherectomy. Now with balloon angioplasty, I know I'm probably superlative and extrapolating, saying, balloon angioplasty is what causes embolization, carotid, post-stenting, whatever. Do you think we need a new filter down right now?
I don't think so. I think you're not disrupting the plaque. You have 7.0? We don't have 7.0 serenator?
They have a 7.0 serenator.
No?
It exists, but it's not here.
Okay.
We only have 6.
PK, what if you have to use like a chocolate balloon or something?
Yeah, no, I'm thinking, hold on a second. I'm thinking about the Boston. Does Barry have the 7.0 cutting balloon from Boston next door? Barry? What is this?
Yeah, so the idea, like he's trying to do, is a little bit more of plaque modification.
What about Barry?
The luminal gain
next door?
And then let's wire it at least. Yeah. And we change it for.
Does Barry have the 7.0 cutting balloon? 7.0 Boston cutting balloon?
Support catheter?
Yep.
No.
Yeah. Gotcha. All right, so I'm just going to wire it by the time PK finds his balloon, so that way we can exchange it for a stiffer wire, and then we can work on our balloon part of it. All right, give me the mic. Can I have introducer, Ray?
Introducer
should be. In retrospect, would you guys have considered OAS here? Because their claim to fame is that embolization risks are reduced. It's their shaped particles are less than the size.
Do they have it
of 2 microns?
No.
Is that something you guys would have considered?
No, I think we're keeping in mind the degree of calcification, the bulk, and having technically an active aspirational component to your atherectomy device here. I think this was the right choice device. I mean, see, the Diamondback, which you're referring for, the previous formerly CSI, like they say, it doesn't have an aspirational component. So even though they say you're right, it's the size of an RBC, 2 to 3 microns. But I don't think with this amount of bulkiness, not everything can be a 2 to 3 microns. So you definitely, we're definitely going to needed this as an adjunctive stuff in addition to your filter. So I don't think that would have given us any advantage whatsoever, even if they claim to do it. So.
Also, David, I don't think OAS gives that luminal gain as you want.
Yeah.
Like Jetstream does. I think the maximum luminal OAS can give you is around 2 to 2.5.
Yeah, makes sense.
If you want something like a 3.5 luminal gain, I don't think OAS will give you that.
Give us a 6.0 long serenator, guys.
You either have to use a directional atherectomy like a large
607
Park or
6 long Serenator.
or a jet stream to get almost like a 3.5 lumen.
Got
I
it.
don't think there's anything else in the market
Yeah.
which gives you that to get the luminal gain.
Sorry. So what we're going to do now is, now that we've done a good job of plaque modification, we've prevented the embolization, we're going to go with the 6.0 Serenator and serenate the SFA. And then for the common femoral, we're going to go ahead with that's fine. We're going to go ahead with a 7.0 Boston cutting balloon if we can get it, or an 8.0. They went down to radiology to see if Dr. Luckstein has one.
Is this wire broken?
It's the posterior tibia, yeah.
Is it?
No. That's
Okay.
I
Oh,
think
that's
it's
just the shadow of the bone.
Yeah, it's fine.
No, it's a transition balloon. It's a transition wire.
All right, so we're gonna now
The
go with
question is,
yeah.
the CFA on the IVUS is around 7.
Actually, it's bigger. I think.
Bigger.
I thought it was
We can do
bigger.
the math, but I think it looks much bigger than.
Why
We'll
not
check
the
on it.
lithotripsy balloon at this point?
I think that it's eccentric for the same reason. And I think it's sort of like you're doing the same thing, with the jet stream did such a great job of cleaning everything out. I think you've got to, in today's day and age, be very cost conscious, and I think you've got to choose the right job, one for the job. We know that lithotripsy is not good with concentric calcium, at least in our hands. I mean, people would argue with you till they're blue in the face, but in our hands, we know it's not excellent with concentric calcium. So therefore, I don't think that it's a good choice, at least for us in this case. I agree, lithotripsy works in a lot of others. I'm just going to balloon the whole segment here with a 6.0 Serenator, just to modify that plaque.
If you review the IVUS of the CFA, and also of course the angiogram, on the CFA, I understand there is there's calcification in the atherosclerotic with atherosclerotic plaque, but I think there is adventitial calcium too. That's why I was saying, how would you get that adventitial calcification gain to expand the lumen if you use
doing it the right way?
Wow.
Yeah, and I think I agree with you, but I think that you've already modified the plaque enough that with a cutting balloon you should be able to expand this plaque. I just don't believe that lithotripsy is going to add anything to this at this stage, in my opinion. That's why I'm not going to do it. I'm just ballooning this here. Here there was no intimal hyperplasia. It was just more plaque prolapse. And I guess with the having run this one through, we're just going to go ahead and just expand the stent a little bit more. We're going to go to super pressures with this particular balloon, which is off-label. Obviously, the 4 or 6 is what they recommend, but we're going to go a little bit higher pressure with this particular balloon.
But remember, Karthik, another thing to add is the idea of getting lithotripsy is causing microfractures in your media. So if there is a non-expandable vessel, then I understand lithotripsy is fine. But if your floor is on.
Okay.
But if the balloon expands well, then you technically are getting a luminal gain. So lithotripsy would not add anything to it, and that's the reason we'll be conservative on the lithotripsy part of the. Of using lithotripsy, especially in this case. Yeah, if it's a non-expanded lesion, then expand because of my non-compliant balloon. Yes, lithotripsy will be the.
I mean, the only question is whether you're going to use drug on this or not. That's the other question, right? So we're going to 4, and then for 30 seconds, and then up to 6, the usual number that we're taught by the Serenator people. And Serenator, we really love this balloon. It really works really, really well in this kind of lesion. I think you needed to modify this quite a bit, which we've done, and now we're going to go ahead and do this. So right here, we're going to let this dwell at 6 for 30 seconds now. Or
David, would you use a DCB for this instant?
For the ISR, I personally would. This is a long segment ISR, calcified disease, so we know the risk is high for restenosis. I definitely would prefer to drug here.
Dr. Krishna?
No, I wouldn't. I wouldn't, because it was all mechanical. There was no intimal hyperplasia. Go up here.
Okay.
And so therefore, I'm just mechanically the proximal area into the common femoral I may, but not in this area. It was all mechanical.
That's
we
the
have
tight
the
spot
IVUS.
right there.
So now see, it's all mechanical. We just expand it.
Yeah, I think you're right. I mean, there's nothing wrong in saying I would not use it because the IVUS evidence is right there. It's mainly not much neoatherosclerotic disease in the ISR. It's mainly because of your prolapse and the stent itself. So I don't know what more DCB is going to add on to the present stent. So, it's a good question about putting money in and for not much gain, and especially in this case. In the ISR
Go up
stented
here?
portion, yes.
But
I
not
mean the
go up
stented
4,
portion.
the usual.
Yeah, yeah.
So now we're just going to go up to 4, and then we're going to go and expand this slowly,
Yeah.
6, and then decide.
So 4 for a minute, technically 6 for a minute, trying to get the.
PK, would you re-IVUS this?
You could. I mean, I don't know how it's going to change your therapy. I only IVUS when I think it's going to change my therapy. And here, I don't think it's going to change my therapy because I decided here I'm going to DCB the proximal aspect of this, and then decide whether to stent versus DES. They've gone downstairs to look for the balloon. Yeah, they've seen. I don't know if Rob has it or not, or Rahul. We're going to find out.
Interesting.
Okay. Down. Oh, 6. I'm
Yeah,
sorry.
give me 6.
Sorry. And then 6 for a minute.
Yeah. Yeah.
Very
I think-
interesting.
Yeah.
I mean, importance of IVUS and primarily to diagnose what kind of therapy is.
So, Karthik, let me ask you this. So, we know there is a proximal de novo lesion extend from the stent to the CFA. You dilate. Do you go upfront DES to give it more scaffold, or you do DCB and then decide whether you need to stent over it? Like your strategy. Well,
So that's why I wanted to IVUS it, Vishal. That was my point. Is I wanted to see the recoil. If the recoil is not very significant and the vessel has expanded well, I would DCB the whole thing. But if the recoil is there, DCB is not going to work, right? That's the primary mechanism of failure for all DCB therapies is recoil of the vessel, right? Am I right, PK, Vishal, David?
No, we agree with you 100%. I mean, we can go out and IVUS it and see what we get. Let's get us an IVUS. I mean, it does. It's not. I'm not going to. I don't think I am.
A great way to go, right?
I am 100% not going to stent this common femoral. So I mean, I know that for a fact. And the proximal looks very well expanded with Serenator. So I'm likely just going to DCB the prox. So I already know angiographically, unless I'm not, I don't have to worry about recoil. I can see it. I don't see any significant angiographic recoil, so that's not going to matter to me. It's just since we're killing time here, I think we might as well just do an IVUS of the proximal into the common femoral.
David is going to sing for us.
And then we'll see here.
Yeah.
Hold on.
Yeah, I think that's a good point. I mean, if you're happy, yeah.
Did it come or no? Not yet.
Okay.
All right, Dame,
Can we go live on the IVUS, please? Oh, there it is. Perfect. We see it. All right, that's your proximal segment right there. Okay.
So much better. There's no real plaque prolapse proximally. And then look at look at that expansion. Much better.
Yeah. The calcium also cut.
And then into the common femoral. Look at that. Wow. There's a little bit. Again, look at the lumen though.
But yeah.
Lumen's much bigger. I
think the gradient.
But I think we have to balloon this. All right, measure the common femoral.
Yes.
Give me a 6060 Ranger, or impact is fine. 6060 impact.
I think it's a great result.
Yeah, I'm telling you, the jet stream. It's just I think you really have to figure out how you're going to do it with the jet stream. I think with the jet stream with the eccentric calcium works really, really well. We don't have a 6060 impact.
Yeah, I think.
I'm telling you, PK, IVUS can sometimes make you very happy or very depressed. So
it's 80, right?
Right. I mean,
in this
that's good
case,
for.
I think it made us happy. Let's put it that way.
No, you're right.
What is the common femoral measure?
0.8. Yep.
It looks like around 7.5.
I mean, the luminal game on common femoral is very impressive. So I think you're right. I mean, just getting a DCB, we should be able to get away with it and give patient a good result, and especially with the claudication part of it.
Lower down, more down.
Yeah. Right there.
Right there.
No, come back up. Yeah, right there.
Right there.
Well, just the maximal lumen of the common femoral.
Yeah.
A little bit more up. Yeah, that's fine.
It's 10. It's huge.
Yeah.
Wow.
Told you, it's huge.
I have a 9 on DCB.
No, it's huge. It's huge. The vessel's huge.
Okay.
Probably 8 or DCB.
You have an 8020 DCB, guys?
Yeah.
40?
40 is fine. Yeah.
Where's the vessel?
Right there. It's just above before the stent.
Yeah.
Little dino?
That's it.
Want to go a little bit
You're
more?
right at the asking.
Go up here.
Go up. Okay.
And give us an 80 DCB.
40.
8040 is fine. We don't have the cutting balloon, right? It didn't come? So we're going to go ahead and put an impact, and then we're using the AV impact off-label at the level of the common femoral. I mean, you could argue that we have a big lumen. We have about 7 lumen. Why bother from a 2 lumen? So I think that, I think it's probably reasonable in today's day and age to drug it. So we'll go ahead, drug it, and then in the next few minutes, we'll be done in an hour. Not bad. Our nurse, Mark, is very particular that we finish in an hour.
No serenade.
Very particular.
PK, Vishal, and David, a question. I know the trials for CFA, this is an ongoing discussion about CFA stenting versus endarterectomy. I know some people really trust the TICO trial. Some people trust the meta-analysis done. Let's start with PK. PK, what is your opinion? I know your answer, but I want to know the audience to know what your opinion is.
I mean, generally speaking, if you just make an objective decision, I think the data clearly supports common femoral endarterectomy. Yeah. There are obviously overlying reasons for this particular guy. He's got systolic ejection fraction heart failure. He's got, multiple other reasons, not COPD. He's not a good anesthesia candidate. There's a lot of issues here why we decided to do this. So I think that, with COPD, home oxygen, all these other things, I think you have to think about the fact that, that this guy would probably do better with this, and also the clinical syndrome being claudication. But if it's a good surgical candidate, I think 100%, in my opinion, it should go to surgery.
Yeah, I think I completely agree with PK. I mean, the endarterectomy data, the long-term follow-up, except for, like he talked about, complications, let's say nerve injury or seroma and all those things. But otherwise, if patient is a candidate, we definitely get our vascular surgeon friends to give us an input and probably get an endarterectomy as the first treatment of choice. And then, if not being like in this case, then of course, DCB is a very good option.
And if you guys, the audience, can go to nyevs.org. There's a beautiful debate between Eric Koss, who's the chairman of vascular surgery at Bordeaux Hospital, and Dr. Jan Gufik, who's the chairman of vascular surgery in Paris. So I think Jan is obviously the primary investigator for the TICO trial, and it's a beautiful debate. You really can learn a lot by going to the website. Okay.
Right. I think just one more thing to add is it's very important, especially in cases like this, to see how the profunda behaves, because profunda, like Yutsakwa, is the lifeline. So I know we want to all get a straight inline flow with the SFA, but without compromising the profunda. And if there is a disease involvement of the CFA into the profunda, then the treatment strategy completely changes. And then rather than, in this case, thank God, the profunda was technically less disease. I'm not going to say disease-free, but less disease as compared to SFA. So we were able to do our CFA into SFA lesion, but I'm sure PK strategy would have completely changed if there was a very tight, significant lesion involving the profunda ostium, and then that might cause a totally different ballgame.
Absolutely. Time check, guys? Okay, down?
Yeah, we're good.
All right, give us the 8.0 impact now.
Got it.
David, what's your opinion?
The data is the data, and I agree with the points that were pointed out before. I just want to really emphasize that, each patient is different. This patient obviously had a higher surgical risk, and Dr. Krishnan always champions the endovascular team or the vascular team discussion, just as we have a heart team discussion. So I think this was a great patient selection for the option that we provided, given the multidisciplinary team discussion, and the right thing was done for the patient. So I think this was a great demonstration of that.
And Karthik, the idea is, remember, he's a claudican, and I think when you do endo, you can see all the things that can happen with endo, right? And embolization, and you almost have to, it's almost like Babe Ruth calling his shot. You got to predict your complication and say that, I'm going to make sure that I'm not going to make this guy worse. And a little die here, guys. So you just want to make sure that you don't make him any worse. So I think we're going to just go in a little bit. Right there's good. So you almost got to call your shot and prevent. You know what? Let me go to another view. Here you have a lot of overlap. So, I just want to make sure that I'm not impinging on that.
SFA,
Mag it up, please. A little die. We can go down a little more.
You can go a little bit lower too.
Okay, let's go up here.
Like it?
Yeah.
Okay.
Yeah. Very nice.
What's nominal?
8.
Okay, we're going to go up to 8 here.
Want timer?
So
Yeah, it's fine. Just
eight
I have it.
atmospheres. Again, I'm not trying to get a perfect result. I do not want to stent. We don't have we would have to go with a non-Supera style stent here because of the size of the common femoral. And so therefore we'd like to avoid that if we can. So we're going to leave this up for 3 minutes. So hopefully we get a good result. Yes.
Yeah. I think your question is, what kind of stent do you use in common femoral? If you have to stent common femoral, what kind of stenting?
Well,
would you prefer?
I'm gonna let Michael talk about a little bit about what are the stents that were studied in the TICO trial as well as in the VMA CFA trial.
Yeah, so a lot of the stents are self-expanding, balloon expandable. There are some that were studied previously. As we mentioned, the prior studies suggest patency rate 2 years based on the TICO trial, 80 to 85%, similar to endarterectomy at that time.
And that was a standard nitinol cut stent.
Correct.
And then the VMA CFA trial, it's obviously the Supera stent that Koen de Loos out of the Netherlands is studying. So those are the two. The problem is the sizing. We have up to 9s, I believe, or 8s. I can't remember the Supera. I think 9s. And then obviously self-expanding, we have all different sizes. So, we're going to leave this up, and then we're going to give some nitro, take a couple of pictures, and then we're going to sign off. As far as anticoagulation and antiplatelet therapy, guys, any thoughts?
A classic aspirin, dual antiplatelet therapy with Xarelto 2.5.
So you would do all three?
Yeah. And then I'll drop in this case, if the aspirin is not needed, then probably just Plavix. Just aspirin and Xarelto.
Not Plavix. Okay.
No.
What about you guys? This is all,
Correct.
Well, remember the new guidelines.
I have really adopted the coronary guidelines very quickly, PK. I go to Xarelto and Plavix. That's it.
Yeah.
Well, remember the peripheral guidelines also say
Correct.
the peripheral guidelines also say Xarelto and Plavix.
Right.
So I think you're not wrong in leaving aspirin out of this, and that's the reason I think it's important to understand that DCB has been studied, and the guidelines suggest for drug-coated balloon angioplasty to use Plavix and Xarelto. So we're going to go ahead and take this out.
Fine.
David, you do the same thing, I'm assuming?
Yeah, low dose Xarelto and Plavix. Yeah, based on the new guidelines.
Nitro, Ray?
Right here. Nitro.
So he's had a TAVR, so we don't have to worry about his valve.
Yeah,
Flush.
that's good. So I think we'll look at the final shots and then probably just wrap it up.
We're going to keep flushing. Yep. Okay.
Yeah. All right, let me fill my catheter up.
Sorry, Ray.
Good.
Fill it. Okay, ready?
Yeah. Ready when you are?
Beautiful. Good flow. Good washout, right?
Nice, good flow. Yeah, very nice, good flow.
I'm going to leave the wire. Pull the proximal wire up here.
Hold on. Yeah, injecting. Wow.
So it's very fast.
Very nice, beautiful flow.
And let's see down here.
Very
Nice.
It looks like the PT is even much better now.
Yeah.
Yeah.
And then always finish with a foot shot, as we always say. Inject.
Mm-hmm. You can already see the arch from the previous.
Very nice.
Yeah, everything is filling slowly, but it's filling.
Yeah.
So I think this is the best we can do, and we'll watch him, and we'll obviously survey him. So it's a good case demonstration of Jetstream choice of calcified lesions, choosing your device based on the lesion morphology, based on IVUS. So anyway, I thank all of you guys. Obviously, the next live case will be the week before Christmas. I think it's December 17th, if I remember right, David.
17th.
Yeah. So make sure you announce that, and we'll see you guys. Thanks so much for your support. Thanks, Vishal. Thanks, Mike.
Thank you.
Thanks, Reka. Thanks, Ray. Thanks, Mac, and of course, Damien. Thank you again
guys
for all
the
your help.
good case.
Talk to you soon.
Thank you.